Thank you for having me here today. Thanks, everybody, for coming. So we're going to talk about clinical decision support. So the first thing we just wanted to just mention, I think you probably figured it out from, from being a part of the course, is before we even get to clinical decision support, we just wanted to mention a little bit about clinical informatics. And as you can see by the pictorial we put up, it's sort of like where clinical care intersects with the health system and intersects with the information and communication technologies. So that's really our sweet spot. It's by taking all this great technology that we have and the business needs of the organization and intersecting it with clinical care. And so as part of clinical informatics, one of the things we do is we make clinical decision support. So as you can imagine, that most people would think that the computer is greater than the brain, but that's really not the case. What really is the case is that the brain plus the computer can be better than the brain alone. That's really what we're trying to get to when we put in clinical decision support. So we're trying to enhance the cognitive function, the clinical decisions, and our own knowledge much better by either making it easier, facilitating it, or taking the situational state of patients or whatever we're trying to study and apply it to make it easier and to inform you better. Okay, so clinical decision support is a lot of fun, and it's also not a lot of fun. So what clinical decision support from an EMR type of thing is that a lot of times, there's many different ways to do it, but a lot of times, sometimes you ask the clinicians, they'll just think strictly of alerts, okay? And alerts are a great thing. It's really wonderful to have alerts to tell you to do this or do that, make sure you stay on track. But it is a big challenge to providers because there's only, the more you alert them, the slower it is for them to sometimes do their work. So really to design good clinical support, one of the things that you really need to do is to go back to the people that use it and try to get their buy-in on what they would like. One of the things that's becoming a little bit more difficult today is that we're starting to get a lot of mandates from regulatory and the government on how to fix things. And unfortunately, there's a set of things that we can go back to the end users and say, wouldn't it be great if we can fix this and make sure it never happens? And then there's a group of things that they come back and the government will say, well, you have to fix that, which could be a good thing, but sometimes they'll be very prescribed on how you have to fix it. And that may not always work in your organization. So that sometimes could be a challenge when we try to implement things because on one hand, we're mandated to do it, and to the point where for something like an alert like sepsis, and it's really important to reduce sepsis, which is a very, very high risk condition that patients will have in the organization. They're infected. Obviously we want to know about them sooner and we want to take care of them better. But the way the rules sometimes are written in the government is if you do the steps, you'll get credit for the alert. It would almost be better in my mind. I wish they would say, Stony Brook, get it under a certain percentage. We don't care how you do it. And then to us, it would be, then we could make the alert that we want to make. But sometimes sometimes we don't have a lot of leeway in order to meet the requirements of really what the ultimate goal is to reduce sepsis. So just to talk a little bit more about it, what we're really trying to do is we're trying to put a little reminder person in your ear. So similarly, like how Jiminy Cricket here is talking to Pinocchio, right? It's just, hopefully, it's supposed to be, in some cases, something to remind you to do the right thing, right? That would be a good thing. And what do we mean by clinical decision support? Okay, going to be clinical decision support is going to be where my glasses went. Okay, here we go. Is that it's when we mean, obviously the main takeaway here is for support rather than making decisions, right? So it's something to remind you to kind of put you in the right context rather than saying, that you must do this. Sometimes we have to say you must do this, but clinical decision support is meant to support you or enhance your own capabilities. Okay. So the goals of clinical decision support are obviously to improve the patient safety and outcomes, impact risk, reduce your risk management dollars and payouts that you have to make, and also to sometimes even help you collect data that you can mine later in order to study things or to report to governmental agencies, like when we have to report on things like sepsis, let's say. And we had mentioned this a little bit on alert fatigue. It's kind of funny. There's almost nobody, everybody likes the alert that they create, right? So when you're using the system and there's plenty of alerts, sometimes the alerts can be just ad nauseum, and you get so frustrated with them, you just keep clicking, ignore, 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 and finally, out of those 1 in 10 alerts out of those 10 alerts you just ignored, you might have missed the one thing that kind of was important to you. So that's why it's really important when you make a decision you get with your end users, you really want to try to make things that really speak to their needs. But unfortunately, sometimes with the way things are rolled out, or there's so many different hands in the pot, or somebody looks at a problem so many different ways, you have to really be careful and judicious about the alerts that you put in the system. So just something to think about is that you will see physicians that will call me and say, you have way too many alerts, please don't put another alert in the system, and then come up with something that is a reminder that only affects a certain group of users, that really should be addressed by process and not necessarily by EMR. So for instance, I get asked at least once a year to put a hand washing alert in the computer. All right? We have a big problem washing hands here at Stony Brook, right? So sometimes when we measure it and we go out and we measure, we're only about 85% effective when somebody goes out and looks at people washing their hands. So the organization has grown and has gotten better, but just a couple of years ago, they would have called me up and said, I need a hand washing alert. All right, now think about it. If you are taking care of a patient on a floor, all right, sometimes you go in a room without a computer, right? To get a good hand washing alert, you would have to get the alert to fire. You would have to log on the computer before you go in the room to go, hey, make sure you wash your hands before going in Johnny Jones's room, right? And then the worst part about it is if you made a hand washing alert, what would happen is times that you weren't going to go in Johnny Jones's room, the alert would fire and say, did you wash your hands? So this is something that you see as your organization evolves, as they put in IT systems. It first starts out, well, everything is well-intentioned, but a lot of times from administration roles and executive roles, like in the world that sometimes I'm running in, right, it's easier for us to check a box and say, oh, we put in a hand washing alert, go tell the Department of Health we're done. And they write a report, they send it to the Department of Health, and now we have to have a hand washing alert forever. We don't. But the thing is that that's really where the clinicians and people like me and leaders like Dr. Heineman have to say, can't do that. It's not an effective alert. It doesn't belong here. And that's really the challenges we get, because it always seems to be an IT fix, but just because it's an IT fix doesn't necessarily mean that it's the right fix, and you really have to go back sometimes and change your process. And just wash your hands. I mean, let's face it. All right. So incorporating CTS helps with real-time documentation, and that's another use that's been coming up with clinical decision support, which is really a difficult thing. So for an example of this is that patients, so many times now, the trick of the regulatory agencies or the trick to make sure that we get high quality marks is to make sure our documentation is good. And one of the things that's really hard when you take care of patients is when you take care of people, you want to write what happened in the note. You really want to focus on their patient care. It's not that you don't want to meet a quality measure, but a lot of times you would write something in your note that says, I did this. But when you write it in a free text form, it can't be found. So more and more, clinical decision support is also making a checkbox, whether it be in a note or be in an alert, for us to check a box to say I did something that might already be in your note. And that's another thing that can be very frustrating to the end users and to people that take care of patients, because they say, geez, I just wrote that over here, why do I have to write it again? The other thing that's also funny is when you deal with people that abstract charts, one of the, is that sometimes they want the language so specific that even if I looked into Dr. Heinemann's note, if she doesn't phrase it in the right way, sometimes they'll reject it and they'll put a mark against our quality. So unfortunately, it's becoming a bit of a game because, as you know, many of these quality measures and things are reported on the internet. So you have things like the NHIQM, the National Hospital Inpatient Quality Measures, and they get posted on your website. There's things like ED posts their times of patients seen and that patients can see them. And then you have organizations like Leapfrog that'll give you grades. And it's really important to, even not only for the quality of the organization, because you want to improve the quality, but just for the reputation of the organization to make sure that your quality, you get the credit for the quality you actually perform. And more, one of the things that's been happening is that we've had great success implementing some of these clinical decision supports to make sure we capture things. But there are times where it's arguable whether or not it really improved the care of the patient, but it did improve the amount of reporting that led to a better star on our quality metric. So it's just something that the organization has a push and pull effect on. We have to find out what drives our quality, what is really something that can change our quality, and sometimes, unfortunately, it's about just making sure we document what we already do correctly. Oh, that's me. That's all me. It's not. Oh, I dropped it? Even better. My glasses. Even better. Okay. So there's been a lot of studies on clinical decision support, but one of the more famous things they talk about is the 5 rights of clinical decision support, which is the right information to the right person through the right channels in the right intervention format at the right time in the workflow. So when we talked about our hand washing workflow just a few minutes ago, this would be something that you would say, gee, this would not be an effective clinical decision support alert. Because like we said, it might be the right information, but if you made a hand washing alert that opened when the Cerner chart opened, you might not be in the right place, it might not be to the right person, and it might not be at the right time. So when we would look at it and say, is this an alert or a clinical decision support rule worthy of implementing, one of the things you can do is go back to a guideline like this and really just critique it first to see if it's even something that should be considered. Okay, so this is a great slide. I didn't come up with it, and Dr. Chris Holwig, who's with me, he's an informatics fellow, didn't come up with it either, but he's going to explain it because I love this example. Go ahead, Chris. You want to come up here?
I think I'll open it up to the audience. So the 5 rights, right? So that's the right information to the right person, through the right channel, the right intervention format, at the right time. How do those apply? So what's the information here being conveyed? What's that?
No more toilet paper.
No more toilet paper, right? And then who's the right person?
Not me.
Well,
Who's the person?
Anybody who wants to use that toilet.
you got
Someone
it.
that wants to use that toilet, right? So we're not addressing people that aren't that don't want to use the toilet. Someone that needs to go to the bathroom, okay? And then what's the right channel? So other examples of channels are, a pager, the EMR, or other modalities. So what's the channel in this case? The toilet. Yeah, it could be the bathroom, right? Right. So we're putting this information out there, not in the cafeteria, not in someone's office, right? We're putting it in the place. And what about the intervention? So some interventions are alerts, and some other things in the EMR or the intervention format. So you're putting it right there on the toilet seat. So within the channel's bathroom, we're now on the toilet seat, and then is it at the right time? Yeah, it's at the right time, right? Because it's when somebody. So, you can think of other ways and notify people in an organization that there's no toilet paper in the you know, you can send an email in the morning, but you know, you're not necessarily letting those people, you know, those people may not be interested in the specific bathroom or that sort of thing. So you have to think about all the different aspects that go into it. So this is a clear example of that.
And by the way, a very well done clinical decision support rule. So, and you know, one that I've actually seen used, but great. But that's actually what we're trying to convey. So when you really apply the 5 principles, this is really a good way to just, you know, think about it when you have nothing else to do in your private life there. Okay, so the right information, we talked a little bit about it, is, you know, but just like in this case, it was that there was no more toilet paper. But the main thing when you create alerts or you create decision support rules, you want to make sure the information that you're conveying is important to the people that are going to use it. The right person. So one of the things you need to understand about building alerts within the EMR system is there's different roles and there's different security roles and there's different ways the application works. And you only get certain choices. So for instance, at Cerner, you can put an alert on chart open. You can put an alert on chart close. You can put in an alert when somebody tries to order something. You can put in an alert when somebody is just about to sign the orders. So a lot of times when we come up with our clinical to support rules, even if we have the right information and we have the right person identified, a lot of times we have a big discussion about what best vehicle we can use to try to convey this information. Because most people, especially when it's an alert that they love, you know, so they'll have a very small group that wants to prevent, you know, toenail fungus in the hospital for people on the 14th floor, and they'll ask you for an alert. They would want everything in chart open, you know. I want everybody to know, every position, everybody to know. But not only would we say we'd have alert fatigue, but it might even be premature. People may not be thinking about this toenail fungus at this particular time. So what you need to do is you need to figure out it's the people that really need to know the people that are ordering it. Is it the people, will they want to know before they order? Will they want to know after they order? Will they want to know, you know, will they want to know as a going away present as they close the chart? So a lot of times you have to have some real good conversations about where that will happen. So the right time is really important, and that has to do sometimes by choosing the position and also by choosing the timing of the alert. The other thing is, in our organization, we have specialty positions for many things. So we'll have a cardiology position, so that's easy. We can make an alert just to the cardiologist. We have a surgery position, so sometimes we can make an alert just for the surgeons. But there are a bunch of us that are that multiple specialties might share one position. And when that happens, that's even why sometimes we argue about whether we're gonna display the alert on chart opening or chart close. Because if you have somebody, let's say like a dermatologist sharing a position with a general medicine provider, okay, the dermatologist is a consultant doctor in the hospital anyway. And in the hospital, generally the general medicine people are going to be the people that are taking care of their hospitalization, their primary doctor in the hospital. So if you're a dermatology consult, half of the alerts about sepsis and all these other things we want to inform them about, they don't really need to see it. They may not be limited to their specialty, but the primary person that takes care of them might be the person that needs to see it. And in a situation where we have a teaching hospital and we don't always know who's taking care of the patient at any one moment because the coverage changes, sometimes we'll use the timing of the alert to help target it to the right person. So the person writing an order tends to be the person taking care of the patient in the hospital. So if they write an order, they'll get their right information. But if we opened up a chart, if we did it when the chart opened, then everybody in that same position when they opened up will get the information, and it might just give them more noise than they can use. Okay. So obviously through the right channels, we push it out, should we pull it in? So one of the things that we'll show you as examples later on is that a push example is like an alert. Somebody opens up a chart in your face, here's what you need to know. But we also have an example, something like health maintenance. So if you were in the ambulatory setting and you were trying to make sure, you were just trying to keep a list of people who might need a mammogram or people that might need a colonoscopy, those don't always need to be pushed in your face. They may need to be just in a place that you need to look at it. This is what you need to do. This is your checklist. That's still clinical decision support, even though it's not being pushed in your face. If it's part of the way you take care of a patient and part of your process, you look at that section in the EMR, then that will provide a type of alert that's not in your face, but give you the information that you need. So that's when we say that's when we talk about the right channels. That's how we would do it. Obviously, there's other things that we can use, pagers, internet, and different types of modalities. Okay, so we'll give you some examples of all these, but you can use clinical decision support on forms. So sometimes when we make a form, like for instance for blood pressure, there's a lot of different ways to make clinical decision support, but part of it might even be just making parameters. Like a person should never have a systolic blood pressure of over 1,000, let's just say. So you would put the braces to a place that's a reasonable level, so that this way so maybe you would set it to 500 or whatever, even though that's still ridiculous. It just helps make sure that somebody just doesn't put in a really ridiculous value in the chart. Sometimes we'll do that with forms where if you have a weight and the person's weight changes like 10% in a day, it's gonna double check your entry, because it could happen, maybe it was an error of yesterday, but we want to call attention to that. So even in forms, you can do it just by how the inputs are placed in. Flow sheets, by giving you visualizations or calling out things that are high or low is a form of clinical decision support. So when you get labs back as a provider, you order a panel and it might have 50 individual values in there. So calling out the things that are high or low or abnormal, that's a form of clinical decision support. Order sets. One of the benefits that we do get with a electronic medical record system is that we're able to make order sets that really remind doctors and caregivers to not forget really important things. So if you had somebody with diabetes and you come into Stony Brook Hospital, we have a automated insulin power plan that would show you exactly how you should order your insulin, how we're going to cover it in the decision of how Stony Brook Medicine wants it to be addressed. And we find that very helpful because we're able to standardize across the organization, but we also find it helpful because there's certain things that not every physician at every time is the most up-to-date on whatever they might be asked to take care of. So this kind of takes that burden away from them. So order sets are another important form of clinical decision support. We'll show you some examples of those later. And obviously the alerts, we talked about it already a lot of. And then there's also reference information. Sometimes it's just about making sure that people understand why we're asking them to do it. Okay. So we'll let you read this one for later. Okay. Okay, let me get to a part that I want to get to now. Moving ahead. Okay, by the way, just in case anybody never saw one before, when I talk about an alert, this is an example of what would pop up representative of what might pop up in your electronic health record. So you can imagine you're trying to take care of a patient, and just when your cognitive functions are at their fullest and you're thinking exactly what you want to do with your patient, surprise, the computer interrupts your process. But it's doing it hopefully for a good way. And in this case, it's giving us important information and also showing us a reference. This is an example of a health maintenance alert. So like when we were talking about before how a patient might come in and there's a list of things that you want to do for the well care of a patient at a certain age group. Our health maintenance alerts are tailored for a person of a certain age and based upon guidelines that the organization has selected for each individual thing. So we will look for guidelines maybe from the CDC when it comes to for flu shots, and we might cite a different reference when we talk about colonoscopies. But if a patient needs a colonoscopy and they don't have it satisfied in the EMR at some point, that will be on the person's list as a thing to do. If a person's already had it, it's supposed to take it off the list so you don't have to do it. But this is a form of reminding, and in this particular case, you have the list of all these things they have to do, and down at the very bottom, when you click on it, it will actually tell you where the reference came from. And that's really important when you make clinical decision support rules, is you not only want to feed the person the information, you want to show them why it is that the computer is telling you to do this, so that they can understand, what the reason is that we selected it to go in this type of pattern. Okay, we talked about the forms where you can actually limit the values and blood pressure entry. And this is an order set. And what's nice about this order set, hard to see, but one of the things that they did well when they created this order set is on this side there's a group of orders. Okay, so let's assume they did a good job with the group of orders because they went and studied it and made sure we picked the most up-to-date orders. But what they also did, which is good, is since this is an insulin power plan, they also put on the left side the appropriate values. On the left side is the sugars that they're following. So this way, as you're writing the power plan, you also can see the sugars that were recorded on the left side, and that's really important. So this way, if you're ordering the power plan and you're not sure, or in this particular case, the power plan might be saying, if your sugars are this bad, do this. If your sugars are that bad, do that. You have the reference right there, so you don't have to go flipping back to the chart. So the information is right there. So then in that case, it's a well-done reference. And in these cases, they also are putting instructions above orders. So even though they're not the actual orders, each one of those lines actually says, if your patient has this, do this. If your patient has that, do that. So it's another form of clinical decision support. So even though just the order set itself is clinical decision support, it's reminding you and actually educating you as you use it. So this would be a very good example of an order set that we use here at Stony Brook. And then, of course, when you have flow sheets, it's also nice to have trending. So in this particular case, it's just a simple lab. We're looking at the LDL cholesterol of a patient. But as you're looking at it, it's also giving you the information of where it was, where it's going, when it was out of control, when it's in control. So that gives a visual to the physician as they're taking care of the patient to say, oh, if the LDL is usually in the range of this, what we expected for this patient, or this LDL is out of range and we should address it, or it helps you trend and helps deliver the information you might need to take care of this patient. Okay, so we're going to wrap it up now, and then we're going to take questions. So because I'm working with Dr. Holwig, who's an informatics fellow that's here from University of Arizona this month. He's a pediatrician by trade, so he had to give me this slide. It's always good to have a wrapped up baby in your slide deck. I mean, how could you not like that picture, right? Okay, so basically what we're trying to do is we're trying to alleviate the cognitive load on the provider and also improve the communication and inform the clinicians so that they can make better decision choices. And actually, right now, most of this clinical decision support, a lot of the clinical decision support is made at institutions and their own committees, but there's a more national movement where there are organizations that will make a great clinical decision support rule and post it on a website so other people can look at it and use it for their organization. So we're really starting to develop communities so if we make that wonderful insulin power plan, rather than just keeping it here at Stony Brook as a trade secret, putting it up there so people can evaluate and see if it fits their organization. Okay. All right, so let me just see where we are here. Okay, So now I'll open up to any questions. Anybody have any thoughts on clinical decision support? Go ahead.
What is the process of making clinical support things? Say, for example, I'm working right now for survivorship for our cancer program.
Yes.
Is there a way that I can do that, or do we have to go through special committees to have that done? Is there a way to allow us to kind of make more customized ones for a group of physicians that treat patients?
Right, so the first thing that's most important, and this is what, especially here, you're going to see a change in our IT very, very soon. And it's something that should have happened all along, but it's kind of a natural process of maybe having this EMR that just kind of got mandated to get pushed in. So what normally happens with anything in a business is that the business people come up with their business case, right? And then IT is really supposed to be a service. Hopefully a wonderful service, hopefully people that collaborate with you. But what's been happening in the last few years is that, and it's not just us, it's everywhere, is that because we have to meet stuff for meaningful use, so we have to do this for this, a lot of times the IT, not even intentionally, is driving the business case. Because we have to collect this money, you have to push this box. And that's still going to be true to a certain extent, because as long as we have meaningful use around and there's money out there to get, or a macro MIPS program, and there's things that we have to do for that, there's going to be a part of that that is going to drive the decisions of the organization and sometimes prioritize that alert over your alert. But I think really what's more important for the way that you to start out is you should actually get the people in your group together and decide what a good, and make a business case for it, all right? You need this because, this is the outcome you want to get because, it's going to save us this amount of money, it's going to help this amount of patients, it's going to prevent this error, okay? Then get somebody in your organization that's a sponsor, typically your chair or your department head, and then in this case, it's probably just easier to bring it here, bring it to a meeting, and we'll put you in the appropriate committee to get looked at, and then we would decide whether or not there's enough of a business case to make an alert. We have now an executive IT governance we started implementing where in some cases, depending upon what the ask is, we actually have a form that we ask you questions to support your case, and then we go and talk about it, and sometimes invite you and whatnot. There's also times where if it's a very low-level thing and it's not going to hurt anybody else, and we can do it easy, and it's only going to affect you and your group, we'll do it. But sometimes so one of the things that we will also get is a group of physicians will come in and say, I want to solve X, but I'm going to make the nurses do it. Okay, so that's great, except if you ask the nurses, right? So that's why we take it into governance, because it might turn out that your idea is great, and it might turn out that that idea is appropriate. But but before I unleash this on nursing, it's very important to get an owner, and that goes even with a lot of the dashboards and stuff we're doing, where you're going to see us make a bigger effort to not only get a sponsor of your project, but also to make sure there's an executive owner. And especially if you have certain end users that you expect to use it, it's really important that they're notified or involved in the design, because sometimes we can't think of all the pitfalls they have. Sometimes we'll find out they already have something that you didn't know about. So that's how it is. But the most important thing for you to do first step is to find out what you want to do and what you want to accomplish, and then we'll consult with you and give you some ideas on the best way to do it.
Alright, so in my health system, we use AutoConnect to prescribe medications, and I have been experiencing a lot of alert fatigue. For example, for the same patient I've been seeing for 5 years, and every month I order the same set of medications, and I know I've tried many different sets. There's like a lot of alerts about you have to check this and that, and I say yes, I check the EKG, yes, I check the TC, yes, I do. I warn the patient about the increased bleeding risk, and yada yada yada. So but each month I have to do the same thing, and I was wondering if I ignore it for once, and then they say, okay, you have ignored all the alerts. The question is, as a physician, I'm always worried. Okay, this 100 times I always answer the question, docs, but one time I was in a hurry, I just ignored this alert. Would you be legally against me if something happened? And then, like I say, okay, you're the one who ignores the alerts.
Yeah.
So I wonder if like legal issue.
So I would just say, first of all, we're concerned about that too. All right, we don't want you to have hundreds of alerts that are, or alerts in a row that are not useful to you. There are times, like we said, so if it's regulatory, or sometimes if it's a corrective action, like sometimes what will happen is the Department of Health will come here, will have a bad outcome, and they'll decide the organization will decide they want to put in a set of lockdown rules that we have to live with forever. Sometimes it's something like that. Sometimes it's because you might have an allergy identified in a medication list that every time you prescribe the medicine, it's going to remind you, even though maybe that can be improved upon. But if you have a couple of specific examples where you're getting 5 in a row for the same patient, we would at least be happy to look at it with you just to see if it's what we expected, even though it just happens to be a burden in this one patient, or if it's something that we did something wrong in the way we implemented that's making a certain type of patients have alerts firing back to back to back, because that's usually not our intention. The other thing is we're going to get some new technology from Cerner soon, which is something we've asked for from the beginning of time, is that we're going to be able to put multiple alerts in a box. So rather than firing 5 separate ones, we'd like to fire one and let you look through them at the same time. But as far as the legal issue you talk about, when you're answering the alerts on the front end, for the most part, we're not recording it in the chart, but it is a piece of data that we can go back into if there was an issue. So you do have to be careful. So for instance, if you answered that alert and something happened like 3 months later, they figured something out, we may not have that data anymore because we're not writing it in a chart. But if let's say you wrote a wrong medication and somebody said, geez, there's an alert for that. We know the patient's allergic to sulfur, and the physician ordered sulfur. Probably within a week or two, we would have that data to go back and say, yes, sorry, doctor, we just wanted to let you know. Now, that being said, that doesn't necessarily mean that you're sometimes wrong to override it, because there are times that we have like medications that we know as clinicians that they come up as an alert and we can move on. But yeah, I mean, one of the things that we're worried about is creating so many alerts. It's been well documented. There's a lot of alert fatigue out there. There's not a lot documented yet on what we can do about it, other than reduce the alerts. Now, a couple of years ago, we made what's called the NOMAS committee, and we will have to do it again. What we do with NOMAS is we get a group of providers together and we look at alerts to try to see what we can get rid of, okay? And we actually had reduced our alerts by like 100,000 in a month. I mean, we have a big organization that fires hundreds of thousands of alerts in a month, and we were successful. And when we do the NOMAS committee, we have a list of each individual alert and what those alerts do, and we're able to look at it and say, and look at it and see, can we tune this alert up? Should we eliminate this alert, or is it a good alert? And sometimes it'll be a good alert, but it fires a lot.
Have there been documented cases of people being sued for overriding alerts?
I don't know. I haven't searched the literature. I'm sure there's somebody out there, but I think it's not. I think it's more still about if you prescribed somebody sulfur that has a sulfur allergy, it really wouldn't matter whether you overrid the alert or not. Either it was the right decision or the wrong decision. You know what I mean? And really what it comes down to is if there was a bad outcome, it's not necessarily because you overrode the alert. It's because this didn't turn out to be the right thing in the patient. So in a lot of times, that's how most things are handled. But as far as from a quality review, right? Like, so let's say somebody had a very minor reaction to sulfur, and it was something that came to the attention of us, but the patient's like, I'm okay, I just had a rash, I just want to make sure it doesn't happen to the next person, and they're not looking to sue. Let's just say having that information, the alert does help us go back to the provider sometimes, and we'll say, we noticed this, and a lot of times they have a great reason. It's just, but yes, we will look at it and review it with them.
One more question.
Oh.
2 more questions.
Just I think more a comment than a question. You had an alert previously for patients who had infection codes, and it was taken out. Now, I presume it was bothering a lot of people, but we were using it.
It's actually not the reason why it was taken out. I'll explain it to you.
Taken out, we were using it, and it resulted in patients being canceled because they showed up at the AC code and everybody missed it. It's in the banner bar, but not everybody audit them all because of the fix you guys came up with.
Yeah.
If you say no, they're other way around, and persist, it works.
Yeah, so first of all, thank you for the thank you. It was like that. And actually, we absolutely need feedback all the time because we can't make anything, we can't do anything without feedback. But in that particular case, there was a system that sundowned and we couldn't do it the same way that we always did it. So, so sometimes it's not always like we just want to take it out because it's too bothersome. Sometimes there's another reason in the background. But thank you for reaching out to us, and I'm glad we found a solution for you.
Just a question on scripts of analytics. How far are we with that? Like if we have setting, if it's known through, efficiency regression, whatever, all the analytic packages there, that's setting, just variables across this Y target variable that you're moving to do something so the patient doesn't develop Y. How far with the CDS or
So two things. One is we already have some examples of that in our system of where we're using information to really prevent harm, stuff that you may not see in the foreground. But as far as the predictive analytics, that's one of the reasons why there's some things like I know Dr. Heineman and I are working with a company right now that does alerting to as part of the macro MIPS program. They're doing programs like to make sure you don't order in the ambulatory, it has some alerts that really specifically look at the analytics and make sure that we don't order this in this circumstance and don't order that in this circumstance based upon, data that's been brought out of Cerner. We also have a population health platform called the Healthy Intent Platform. And what we do with that a lot of times is that they're not always pop-up alerts, but as you may know, your colleagues are starting to get dashboards. And in cases where we have focus on from the quality groups that we need to fix a certain thing, we're making a lot of dashboards on different types of diseases to give people insight as to things that are trending and things that have already happened that need to go back and be readdressed. And then the other thing is we have Dr. Saltz here. And one of the things that Dr. Saltz and his group are charged to do is to make those kind of algorithms for the future. And then, of course, we have vendor products that we either have bought or continue to buy.
Thank you.
Thank you.